All right, guys, welcome to another episode of the OT for Life podcast. I can't thank you enough for joining me today. And if you've been a part of pretty much any discussion about OT on social media, you'll probably recognize our guest today. Alexis Joelle is an occupational therapist and OT consultant who is so passionate about her profession. And she's also just a huge advocate for recognizing the distinct value of occupational therapy and what OT can bring to the table. She's a dedicated clinician within the acute care setting and also an established mentor to OT practitioners and students. In this episode, we chat about her work in acute care, how she promotes and maintains an occupation-based mindset within the hospital setting, and her passion for instilling confidence and a growth mindset for our OTs. Let me tell you, I absolutely loved my chat with Alexis and left feeling so inspired. I hope you enjoyed as much as I did and find your own motivation and inspiration from her words. If you're interested in occupational therapy, this is the place for you. This show aims to explore our profession by sharing who we are and what we do. Because for us, occupational therapy is more than just a job. Hi, I'm Sarah. Welcome to OT for Life. Hi, Alexis. How are you doing today?
Oh, Sarah, I'm good. I'm hanging out at home on a nice sunny day and sipping some tea. It's beautiful.
I love hearing that. Yeah, it's so nice that it's starting to warm up. I think I'm fingers crossed, we're kind of through our rainy season right now. So it's been absolutely beautiful seeing all the flowers and everything since the rain.
Oh my gosh, all the wildflowers have been incredible. Can I just say, it's so funny that most conversations start off with the weather.
I know.
Like, so I'm going to be very occupation-based here. We spend our time occupying our time around the weather. Like, we are either inside, sipping on cocoa on a rainy day, maybe doing some puzzles, I do, or I'm outside hiking or at the beach or whatever when it's really nice and hot.
Yeah, it's so funny that you said that. For me, I feel like because I work in driving to my clients' houses, the weather significantly impacts my day-to-day routine. If it's pouring rain, I'm trying to park closer. If it's starting to get hot, which is where we're kind of in that transition phase right now, I'm starting to get nervous because it's going to be really, really hot. And the summer, we're going to start sweating. And there's no air conditioning, no fans. And so I think that's where my brain is. I'm like, oh, it's getting hot. It's going to be so much harder to do my sessions because the heat it's a lot.
So how do we adapt for that environmental context?
Yeah, that's a good question. Unless I could tote around a little air conditioning. No, just kidding.
Yes, a fan. You could do manual or electric, whatever you want.
Uh-huh. Yeah, so I'm excited to have you on the show today. We've been talking about this for a long time, so it's really cool to have it actually be happening. I was sitting and I was reflecting today, and one of the things that I think is so cool and so unique about our profession is that every therapist, their day-to-day life looks completely different from the next therapist. And I'm really excited to kind of chit-chat with you and hear a little bit more about your practice area, because I have to admit, I'm pediatrics. I've been peds brain my entire career. Even throughout school, I've had very minimal exposure to working in hospitals. And so I'm just really curious to kind of hear more about what your days look like and kind of what you're up to these days.
I love that you asked that question, because when it comes to the individual or the human that I'm serving, they just happen to be adults, but not always. Well, in the traditional sense, when I think about acute care setting, which is where I work my 9 to 5, not only as a practitioner and a supervisor of an OT department, I will serve majority adults, older adults, but the occasional teenager or mom of an EQ infant, which is once in a blue moon. And so it's interesting that you brought that up in the fact that, I have a kind of pediatric experience, pediatric mindset, but I'm thinking, whoever we're serving, like, and this is how I believe and how I practice, whoever we're serving the human and the individual, wherever they're at. It's really convenient to have expertise in older adult setting or pediatric or an EQ setting. But at the end of the day, like, I just think about how does this person occupy their time and what skills do I bring to the table to help them? So what my day really looks like, I can go from room to room, see my clients, whether eval, occasional treatment, might be coaching or advising my department employees, come home advising other OTs in the world via social or the internet world. But at the end of the day, it just all comes down to serving humans, for me, at least. I'm excited to get into some of the details of like what acute care looks like in comparison, especially if there's any listeners out there that are thinking about going into adults or going into this type of avenue. But I do think about it more broadly when it comes to how I'm serving each day.
I like that you said that because, like, literally as I'm saying, I'm Peds brain. Most of the time, yes, I'm working with the kids, but I'm still dealing with the parents. Like, I'm never just walking in and it's like, oh, here's a kid. Okay, you're going to work with it. And so, but it's a different practice area. And there are differences in the way that it looks, but not necessarily in the framework and why we're doing what we're doing. And so I love that you just kind of were like, it doesn't matter if I'm working with an adult or an older adult or a pediatric client. It's still going to be that kind of that same lens and that same kind of occupation-based practice that we are utilizing in order to do our job.
Mm-hmm. That's really our secret sauce to what we do as a profession, is really identifying and facilitating that occupation-based access.
Yeah. So acute care, could you take a minute and maybe just explain, because I know there's lots of different areas like within the hospital setting alone, and just maybe specify specifically what acute care even means, because I'm sure we have some people that might not have been exposed to that practice area yet. Because I know there's like acute rehab and there's step downs and there's all sorts of different realms that you could be in just specifically within the hospital.
I'll first start off by categorizing each of those settings quick and then go into the deep dive of walking you through as if I was a client that walked into an acute care setting. So let's talk the big building hospital, okay? Many settings that can include, and of course, listeners, if you feel like there's another setting in a hospital, please tweet us or let Sarah know, hey, there's this one too, because I only know what I know. There is the psych inpatient, which patients are admitted for psychiatric related conditions that might have occupational therapists. I personally don't work in that setting, but it exists in hospitals. There are outpatient settings in hospitals where people come for their outpatient service, but they don't get admitted. There's acute rehab where you have intensive therapy for 3 hours at a time. It might be in conjunction with speech and PT. There's acute care for inpatient, like typically physical disability or trauma. I personally like to categorize where I work as planned and unplanned admissions to the hospital. And so to take you through kind of the journey, we'll take two scenarios. So one client might come in, get admitted to the hospital for a routine joint replacement. We'll see them the day after surgery and teach them everything they need to know about accessing their occupations post-surgery so they can go home. Or recommend to go to some sort of facility or rehab after that if they need it. Or there's the unplanned individuals that come into the hospital. They might be sick with the flu. They might come in for a traumatic injury. Could be head injury, could be orthopedic, unexpected medical conditions, whether it's cardiac or pulmonary or you name it, what it might be. So I like to categorize individuals who come into the hospital in those two ways, because in both scenarios, the clients are getting medical intervention, and when they're medically stable, they leave us. So OT will come in, do an evaluation if it's appropriate, and then typically we're recommending what they need when they leave, whether it's recommendations for more functional, occupation-based rehab in some fashion, wherever their discharge is next, or recommendations of how they can access their meaningful activity before they go home. So short stays for these clients, sometimes clients are not even technically admitted on the books, but they're under what's called observation. So there's not necessarily a medical intervention for them, but they will kind of pass through the hospital before they go home because they came for a reason. Perfect examples of this are someone who's sustained a potential TIA, transient ischemic attack, and they're determining if they actually had a stroke, and they actually didn't have a stroke, so they send them on their way. They just watch them and monitor them. So that's kind of in a nutshell where I'm at. Our goal really is to help support them in the beginning journey, whatever that might be in their planned or unplanned admissions.
So I know you mentioned short stays, and I feel like to different people, that could mean many different things. Like to me, a short stay would be like a couple months, like working with a client, because I can work with clients for years. So when you say short stay, what specifically are you meaning by that?
Okay, so this is a few-part answer.
Okay.
Yeah.
Not a short answer for a short stay question.
Right? It really is. It's ironic, right? Because simple descriptions, just like occupational therapy, can mean very complex and dynamic circumstances, right?
Yeah.
So typically, clients who are admitted, they're expected to stay short term. So for example, in my hospital, and this is not everyone's hospital, somebody who's had a hip or joint replacement will likely stay 23 hours. They've had their surgery, we see them for evaluation, and they go home and they're on their way, probably for home health therapy or not if they're doing fantastic. That's the average. And if there's complications medically, let's say they have comorbidities that are keeping them in the hospital for more medical intervention, they'll stay longer. So we'll see them while they're there if we determine it's clinically reasonable. And for clients who have had polytrauma, which they've had multiple fractures, a head injury, they'll stay until they're medically stable. So they need to rule out for scans to make sure they're clear, or they've identified all the injuries to determine that the client is medically stable and doesn't need any more medical intervention. Once they're stable medically, the client will discharge, and we'll see them. I typically see clients that have a traumatic experience like that 5 times a week. So that's like my treatment plan. But they may not stay that long, depending if they're medically cleared. They may be cleared in 48 hours. They may be cleared in 2 weeks. However, here's the exception to the it depends answer. If the client doesn't have insurance and the client is having a difficult discharge plan, or something is getting in the way, some sort of barrier is getting in the way of their ability to leave the hospital, we get the freedom to actually see them much longer. We end up being their quote unquote acute rehab. We're the ones that get to treat them as long as possible because they just happen to not discharge. So even though there's a system in place that clients who come into the hospital in the acute care setting, they're there until they get medically stable, we are fortunate enough to be able to see them until they're functionally stable in those circumstances. But even though in our OT brains, we want to help support and maximize clients' ability to get better to their fullest potential, we may not necessarily see that all the way through in the acute care setting, just in the beginning stages traditionally. We get those few exceptions where we get to actually take them through their rehab process. So it really depends. And there are longer short stays. Like, for example, a patient who goes through a heart surgery will probably stay 5 to 7 days in the hospital until they're medically ready to leave. So, yeah, that's the depends.
Yeah. Well, and now it totally makes sense, because when you were talking earlier, you were saying that you mainly do evaluations and the occasional treatment. So when they're only coming in and they're there for a day, maybe a couple days, yeah, you're seeing them once, and then potentially you might see them like 1 or 2 other times, but you're really kind of coming in, doing the evaluations, and then my guess is you're giving as much education as you possibly can when you initially start seeing them.
Yeah, we literally have to think about, okay, if I had 30 minutes with this client and that was all I was given, what is the best advice or what's the best treatment plan I can give this client right now if they were to go home with no services? Or what is the best that I can give them to set them up for success going forward, in their rehab journey if they're going that way?
I feel like has its own challenges in itself, knowing that you have a very limited amount of time and you might have some people coming in that were not planning on being there. They were not planning on seeing you. You really kind of have to read the client where they're at, utilize the knowledge and the skills that you have, and then do as much as you possibly can to set them up and get them on that correct path, even though you might not be seeing them much longer than that. And really I love what you said in the beginning, supporting that beginning stages for them.
Exactly. And that's exactly why I love acute care so much, because you get to be the catalyst for their journey. You get to set them up for success. And no matter what obstacles they're going to face along the way, expected or unexpected, you get to be there in the beginning. And that's so rewarding, at least for me. I know that there's some humans out there that may not feel the same about acute care as I do, because it's very intense on other aspects. Clients are critically ill in the ICU, or maybe there's certain circumstances that hit close to home in terms of conditions that clients may have. It's fast paced, but I got to tell you, there's no better joy than being able to help someone in the beginning aspects of their journey.
So I'm like over here and I'm smiling because as I'm listening to what you're saying, I'm immediately connecting it to my practice area. And that's one of the reasons that I love working in early intervention, because a lot of the times I am the very first therapist that the client is meeting, the first one that they're working with. And I get to be there from the beginning, like literally the beginning of the child's life. And that's been one of those things that over my years of practice that I've moved towards trying to get there in the beginning, because so much can be done in the very beginning, in the very initial stages, whether it's recovery, rehabilitation, or helping them grow if they haven't even learned those skills yet. And so it's so interesting that here I am thinking, what you're doing is so different. And now I'm like, no, we're doing the same thing. It just is in different settings and our clientele is different. But yeah, we're there from the beginning and we're really fostering that growth right from the get-go.
And it's so interesting. We were talking about the beginning stages and how much we like it. Coworker, well, now good friend and colleague of mine who actually moved on, she had always worked in acute care. And 8 years later, she decided to kind of scratch that itch she had, because she was always curious about what was on the other side. Where do our clients go? What are their outcomes? Like, how are they doing now? Because we saw them from the beginning. And so she decided to go into home health blind because she wanted to see what it was like on the other side for our clients. And sure enough, she obviously opened her eyes to the whole new world of what OT truly can do in a natural setting. However, she also noticed the same gaps that we're talking about, that she is motivated to change on that end. Oh my gosh, there's so much this hospital can do in this rural area to help set these clients up for success because of what I'm seeing now in their home health setting. And just to see that whole full circle effect is so powerful, and how important it is to embrace each other's settings so we can understand how it affects the client as a whole person, and to get that diverse connections amongst each other in their profession and other disciplines, of course, to be able to fill those gaps in for our clients.
Exactly. Yeah, actually, when I interviewed Dr. Michael Roberts, he made the exact same comment where he was working in the hospital and then switched to doing home health. And he made a comment about how much better of a therapist he actually became once he understood and saw what was going on in home health and working with the clients and the patients within their houses. I totally agree with what you're saying. Yes, like we can be amazing at what we do in our specific practice area, but we have to have an understanding of what either happens beforehand or what happens afterwards so that we can best support our clients. But I was going to ask, is there a difference going back to when you were talking about like somebody that comes in planned and somebody that comes in unplanned? Is there a difference that you notice in working with those types of people? Like, is one harder? Is one easier? Is it more emotionally challenging? Like, is there any difference that you notice?
Yes, totally. So clients who come in for planned or elective procedures know what's coming in terms of the process. So clients who go through a hip or a knee replacement actually have what's called a joint clinic, where they go to a pre-operative class. They get educated on what to expect, including occupational therapy coming to speak to the class about how to set up their home for success so they can stay independent and do what they need to do post-operatively. And their willingness to work with us is beautiful. Is there fears and anxieties about going into a procedure? Sometimes, but our systems are set up in a way where it's all anticipated and clients can go through as smooth as possible, depending on their individual needs and all that kind of stuff. For clients who come in for elective procedures other than joints, we don't have preoperative classes, but they are still open because getting their buy-in is easier in that we get to frame it in a way of, we're here to support your independence with the thing you just had done. And so they still are appreciative and willingness to work, and things are somewhat expected, right? But with clients that come in for generalized weakness or the flu, they're not quite sure why we're there. It's a hit or miss whether they accept who we are. So those are kind of 50-50 shot, right? But then you get your clients who have sustained that multiple trauma or polytrauma, and they're experiencing something that is so powerful and unexpected that we may not even be ready to help them until we check in with how they're feeling. And we're kind of on navigating where they're at in that moment of that unexpected event. And so every client is different, especially if they're critically ill, where we kind of go where the client's at in that moment, and we reflect moment by moment and figuring out, what do we need to do to best support them in this second? How are their vitals doing? Are they good? Are these lines manageable? Because they're typically attached to multiple lines, especially in the ICU. And things can feel very intense and critical. Now, I wouldn't say that that scares me. However, it scares me, if that makes sense.
Completely.
Like, when I'm in the moment, present moment, it's exactly where I need to be. However, there's unexpected things that happen that you're just like, okay, I have to be on it. And I have to figure out how I can best be there for the client while making sure that everything is kept safe. Now, when they've graduated from those critical care units and they're on more of a surgical floor or a medical floor recovering, then you start to get more into the psychosocial part of it. Are they ready to receive what you're providing them? We may know, or we may think we know, what they want right now or what they need in order to have better long-term results for their recovery in terms of independence. But if the client is not ready to receive that because all they want to do is go home right now because this is a foreign building and the medical system is foreign to them and they're experiencing the hospital for the first time, we need to be right there with them so they can be ready to receive what we have to offer. And you have to do that in such a short time. So I love the challenge of that, but you got to do it quick. And so sometimes pressure from needing to get from client to client can become a barrier to that rapport. But it's all the more reason why we have to be really keen about our ability to build rapport fast. So it's a challenge for sure, but it's also a really big opportunity to connect with your clients better than anyone else in their journey of recovery.
And it almost sounds like it is constant assessment and reassessment and reading of the client and trying to understand where they are at like every single moment. Really like that importance of getting the buy-in. Like I hate that word. I hate that phrase.
I know.
But getting them to understand what it is that we can help them with and how important it is. Because as you were saying, like people just want to get home. And I'm like, yes, but they need the skills to be able to do things once they get home. Like they're not going to be happy if they just get home and they can't do anything.
Right.
But getting the patient to understand that, especially when it's something that they're just still trying to process. If it's something that's like unexpected that just happened, maybe they're in pain or who knows, like whatever is they're going through at that moment. And I love that you kind of just started talking about these challenges already, because that was going to be my next question of what are some of these other challenges that you deal with, that you face within the acute care setting?
To add to the challenges related to diagnosis, I would say even neuro to like stroke or traumatic brain injury, that is such a impact for some of our clients that, especially if where it's impacted their brain or their body, where they can't notice the insight to what's happening physically or notice the insight of what's happening cognitively, it adds another layer of challenge to bringing that light on that for them so they can see. And I agree with you, by the way, 100% about the buy-in word. It's funny I said it, and I also recognize that any like easy word we can catch and put out there, there's always a really long description that would serve better. But it's a matter of facilitating their ability to see how what I offer applies to their life. And that takes so much skill, because it's not on my time. It's not, even though we'd like to think it's on our time, it's really on what their perspective is on all this and how we can help be that gap for them while they're trying to navigate, rather than us saying, but wait, as I'm like raising my hand. You can't see this, but you need this before you leave. Mm-hmm. No, it's really a matter of not convincing them you need what I offer. It's a matter of convincing them I'm here for what you need from me.
Oh, I like that.
And yeah, and it's so with those challenges, sometimes we have to be really quick about being straight up with our clients, like with clients with a brain injury and with a stroke. I sometimes give them tough love. They don't know me that long, and I have to tell them straight up, like, this will impact this, or I will have to have them do something to show them that this is impaired in order for them to see that there's light at the end of the tunnel and that they don't have to toughen it out and say, I'm fine, I'm independent, I can do this. And I think what is really hard for us as, and I'm going to put this as nice term as I can, able-bodied, you know Samia, right? Samia Rafidi. I went to a lecture of hers at OT of California's conference. I don't know if it was last year or the year before. She was talking about ableism. And ableism basically is like, it's a bias that we have as able-bodied people, including occupational therapists having ableism, and how we see someone or a client in a different lens because we are able-bodied. And sometimes that bias can actually get in the way of our ability to actually help our clients. And when I think about our clients who have always grown up with or always had some sort of impairment and they do things differently to access activity independently, they should be our teachers, actually. And they should tell us how they access their activity or meaningful activity independently, because we shouldn't be telling them how it should be done. However, with our clients who have a new impairment, such as a brain injury or a stroke or whatnot, we have to show them through their abilities pre-existing what's happening, so then they can start to rebuild their foundation to access those things again. Does that make sense?
Mm-hmm. Yeah, it is. Like, yeah, that, like the whole ableism thing, it is hard to put yourself in those situations that some of our clients, some of our patients are going through if you've never like lived through it yourself. Of course, we've had the experience of working with lots of different people that have gone through similar events or similar traumas or injuries or anything like that. But yeah, you don't really get that full appreciation unless you've actually gone through it. And I know what I always try to do, and this is such a small scale, but at least for kind of that awareness piece, anytime that maybe I pull a muscle or I strain my back, or for instance, last week I hurt my wrist. No idea what I did, but my wrist was really hurting for a couple days. And I took note of it, and I took note of all of my occupations that were impacted just because of something. For me at that moment, it was very small, but it was significant enough to impact some of the things that I was doing. And I wasn't able to work out to the full extent that I typically work out, even at work. Like, I was actually trying to show the parent some positioning techniques, and I couldn't weight bear on my left wrist. And I'm like, I'm sorry, hold on, don't look at this because I'm doing it completely wrong, but I'm in pain right now and I have to adjust for it. And like, that's what I try to do as much as possible anytime that I experience something like that, and really see when you have limited function in any aspect of your life, how it actually plays out in terms of what occupations you can and can't do at that moment.
I have to just say, this is one of the reasons why I think we connect so well, Sarah, is because you think everything OT. Like, everything you do with your time, you're like, okay, OT application applied here. Like, I that's how I live and breathe. Like,
Yep.
the passion just like seeps through. It's pretty amazing. Yes, OT soulmates.
Totally. It's like, yeah, I mean, of course, it's like one of the reasons I picked the name for the podcast, because it's life. It is life for so many of us therapists. It is really hard to kind of turn off our OT brain and everything. Yeah. We're always looking at life just slightly differently.
What I wanted to add on to that was clients who were able before and clients who are not able now due to neuro-based diagnosis like stroke or brain injury, showing them the very things that they do every day is so powerful, because then they can see what they can't do in order to start building that foundation of how to get back to that point where they can be able to do again.
I like it. I like that.
Yeah.
Yeah. So this is something that I've been kind of thinking about for a while. And again, because I'm not working in a hospital and I have that kind of limited exposure. My exposure was when I was a student, and that was 10 years ago. So it's been a while. But it's kind of one of those topics that I feel like comes up a lot within our practice. It's the whole concept of occupation-based practice. And I'm really like to know, being that you're working in a facility and you have such a short amount of time with all of your clients, how do you keep your practice? How do you keep your job as occupation-based and as occupation-centered as you possibly can?
Yeah. So I have to thank the inventors of the occupational profile template and the inventors of the routine inventory checklist, and just my experiences being an occupational therapist, to ask about how a client occupies their time to be able to keep it as occupation-based as possible. Sounds like an easy solution, but sometimes it really isn't, right? Because of time, productivity, and all the other challenges that we may have in our setting. But the truth is, the way that I keep it occupation-based really is getting into the nitty-gritty of how this patient does their day from morning, noon, and night. And whatever's going on with them right now, for the reason why I'm seeing them, we tie that in. So, for example, if a client is coming in for a fracture of their femur and they had an ORIF, an open reduction internal fixator, which is basically a plate and screws in the femur, put in to put the bone together, and they're not able to put weight on it for X amount of weeks so it heals, and we're trying to navigate how they're going to be able to access their basic activities of daily living. But then I go beyond that. How does this client spend their leisure time? What does this client like doing with their day? And what do they have to get done? And that varies, right? If a client loves to knit and sew and crochet and they do a lot of sitting-based activity, they're going to be fine. And we're going to, encourage them to stand up and mobilize as much as possible to encourage them to retrieve their supplies while they do that. But at least we know that their non-weight bearing precautions won't get in the way of their meaningful activity, and they'll have some fulfillment during their recovery, right? But I also think about how, let's go another level. Do they want to go do their laundry still? Do they want to go to the grocery store while they recover? Is socializing with their family and friends important to them while they recover? How are they going to navigate that? So I'd like to think about, how is this client literally spending their time morning, noon, and night, and with whom, and in what environmental context? And that's really how I keep it occupation-based. So I may not be able to cover everything in an acute care setting with them, and we may have time to actually practice the basic ADL, but at least I want to provide them the tools for those dynamic activities and those activities that they will access in the community or in their home or whatnot, so they can feel successful through their own recovery. I want them to be able to get the tools they need to be their own OT, so they can apply it to their own occupations, no matter whether or not I'm there.
So it almost sounds like, rather than on a very functional, okay, this is the tub, this is how we're going to do the tub transfer, or here's the sink, this is how we're going to brush our teeth. It's almost more of a mindset that you're trying to instill in your clients and in your patients. Okay, this is what's important to you. These are the limiting factors, or these are the reasons, these are the precautions that we have to take into consideration. But you're almost just changing their mindset so then they can go apply it to their life, regardless if you are able to be a part of that or not.
Yes. Sure, we have to practice that tub bench transfer. They have to be able to know how to get in, because I will tell you, 99% of my clients, they'll think they know how to get into the tub with a non-weight bearing leg, and they just think they're going to hop. No. We still have to practice.
Yep.
However, if they really want to access their meaningful activity and not have to feel burdened by their family, or they want to still make themselves a snack, because they love to cook, and not have to wait for their husband or son or whoever to get home, we still talk about those meaningful things. And so that's why I love this job, because we don't have to just check off the boxes. Yes, we may feel like we have to check boxes off, but we're not here just to check off the boxes. We're here because we actually make a huge impact on our clients' lives. And I want to give them the most bang for their buck, right? I want to serve them hard. Yeah, I think that's also what can make this setting very mundane. And for a lot of therapists, and it may not, I don't mean just occupational therapists, I mean any professional in the hospital, is when we're doing kind of those, I don't know if this is the right term, rote activity. Mm-hmm. If we're just doing, checkoffs of the task list and thinking this is all we can do, are we really showing up to a job that we enjoy? I don't think so. I think it's super fun because it's always a new adventure for me with my clients, because I get to find out who this person is. Every client's different, right? Mm-hmm. They may all have the same diagnosis. Let's say they have such a specific, they have a right-sided MCA, CVA, right? But every client, their occupations are so different, and how they get to access those things are so different.
Yeah, I'm gonna pause you for a second, just in case our listeners don't know what a CVA is.
Yes, it is a cerebral vascular accident.
Thank you. I know so many times we'll throw out terms, and I'm following you, but I just want to make sure that everybody else knows what we're talking about.
No, totally, and I appreciate that. And then, but that's my point, right? We could look up on Google, that one diagnosis, and we worry, right? Oh, wait, I have never heard of that before, or I don't know that term. I have to check the right intervention. But let's go back to our root. The right intervention is right in front of us, our client. Our client is telling us what they need. We just happen to have precautions or restrictions that we have to kind of work around with that and adapt for.
Yeah. So it's almost like it goes hand in hand of having an occupation-based practice as well as a client-centered practice. And really, I mean, I guess you could be doing occupations, but if they're not meaningful to the client, then really what good are you actually doing?
Mm-hmm.
I've heard this so often, and I kind of want to hear what your take on being kind of in the practice area that you're in. But I hear time and time again that our profession has moved away, and I hate saying this, it's really unfortunate, but that our profession really has moved away from making it client-centered and making it occupation-based. It's so foreign for me to hear because I'm in my clients' houses. I am using their furniture and their materials, and everything I'm doing is so client-centered and occupation-based. But time and time again, I'm hearing these struggles of other therapists that are in facilities that it's not really at the forefront of what they're doing. It is these checklists. It is, okay, can they do this? Great. Okay, then they can go here. And there's been kind of a disconnect, at least in what I've heard from people. Are you seeing that where you're at? Or have you come across that in other therapists that you've talked to?
Absolutely. This is a multivariate question as well. When I first started at this hospital, I definitely saw that happening. And of course, I saw this when I was a traveler in skilled nursing facilities, especially. And I even saw this not as much in other settings, actually, because the other two settings that I did my travel assignments were very occupation-based, client-centered, and had a lot more of a utopia feel to them, where there wasn't really a dictation of insurance and things like that or a system. I think where a lot of that stems from in regards to steering away from the occupation-based models is because we work within a medical model and a system where we're relying on feedback of how we should do our job rather than defining how we do our job within the system we have. And that really takes a lot of courage. It takes a lot of self-reflection. It takes a lot of understanding of, okay, so who am I and how do I fit into how the system is right now? And here's the other thing, evidence-based practice. It doesn't just go in alignment with what research articles already exist. We have to create our own evidence in our own settings in order to advocate for ourselves within the settings. And I think that that's also a missing component that gets in the way of occupation-based practice because we're so focused on getting the task done and getting the documentation done and all these to-dos that we've been told. However, if we don't do soul searching on ourselves and understand, okay, well, what do I bring to the table rather than what do they expect from me, then we really can't do our job in an occupation-based fashion. There's a lot that I have to say about that. And there's a lot that I'm reflecting on that because it's actually it's one of the very things as to why I'm here and why I do my mentorship. It's a mindset shift, really. And unfortunately, it's a systemic issue. It's not a therapist issue. And that's one of the reasons why I'm here supporting our profession, because it's not their fault. Like, it's not their fault why they practice the way they do. It really is a system issue for certain therapists. So with that, the bright side for our hospital, when I stepped into the supervisor role unexpectedly, it wasn't something I asked for. It happened for many reasons. I was not okay with the status quo, and I had to jump in tippy-toe initially because the water is a little cold, right? But I had to jump in and figure out how I wanted to change with the system, not against the system. And it's been pretty amazing to see how it's flourished since I started as a supervisor there, and how our department now is so occupation-based, and we understand the challenges that we're facing in the system. So that's actually something else we didn't talk about in regards to what challenges we face in acute care. Insurance is a huge challenge. You know, some of our clients, there's a couple of things, and I'm being candid here because it's important to talk about this hard stuff.
Yes,
but
I appreciate that you are.
Yeah. Some clients who are insured have a certain insurance that covers them for rehab. So they may have a certain aspect or tier of insurance, but they may not be able to get to that acute rehab that we're recommending them because their insurance denied them, because that's the plan they have. Or the facility can't accept them for whatever reason, and I'm not going to get into those details. But we have to work with the system that has been provided for this particular client, and we have to give them whatever we can within that moment. But we also have to accept the system as it is. So that's one scenario. The other scenario is uninsured clients who don't have that access at all. So it's not that situation where we would love to give them the optimal rehab in an acute rehab setting, but they can get skilled nursing services because that's what their insurance dictates. No, we've got those who are uninsured who have nothing. And we have to really pull out our tools in our toolbox to figure out how we can help them. And you're navigating a whole other gamut of waters, right? When it's not just what we want to provide our clients and be occupation-based, but we're also trying to factor in what the client even gets at the end of this. And that's really can be difficult, but it's possible if we think differently about each of those cases. Is it going to be 100%? No. And I think we have to give ourselves grace for that. And I think that's also where a part of the removal of the occupation-based care also lies is I think if, and this is just might be an opinion, I think sometimes it's scary to try something if you're unsure that it's going to be carried out at the next level, or you don't want to disappoint your clients. So why try? And let's just do this thing that we know and keep it in a box because we don't want to let our clients down. And if we have submitted to a system, then it's really easy to not give our 110% that we really want to, that satisfies our joy in what we do.
So I want to go back to something that you mentioned because I'm so glad that you brought it up. And I think it's a really important thing to just kind of highlight. And you said that therapists can't blame ourselves. It's not necessarily it wasn't caused by us. It was caused by this overarching kind of systemic issue within healthcare and insurance and the way that everything is set up and the way that things have kind of shifted over the years. And I think a lot of people have felt like we're the ones to blame, that we let it get to this point. But when you are trying to navigate a system that is ridiculously complex and constantly changing, and then you're having the added responsibility for your job, productivity, time, stress, all these other things that you're also trying to kind of navigate around, you can see how little things will just change. And then all of a sudden, we're way far away from where we want to be. And I really like the fact that you said, like, the therapist shouldn't blame ourselves for where we are now, and that it is this kind of awareness piece. It's this mindset that we have to have. And I think rather than just say, oh, well, too bad, we're here now, this is the way it's going to be, it really is, all right, we're here now, what are we going to do about it? And how are we going to change and get back to our roots and really what we can offer as a profession?
Exactly. And I want to bring up something that one of my own director of rehabs has taught me in the grand scheme of the system. And I love her because she stays grounded to her profession through thick and thin of what's being told to her. She says, it doesn't matter what insurance can cover and not cover. It doesn't matter the expectations of a quote higher up. We still have an ethical duty to justify or show and demonstrate that we can't justify in our documentation because it's coming from a clinical judgment. We still have to recommend our functional recommendations or lack thereof, or what's going to set our client up for success despite what everything else says. We still have an ethical duty to do so because it's our licensed duty. And that can weigh a lot of responsibility and heaviness on our shoulders, I think, because we want to do what's right by our boss, or we want to make our job easier, or we feel pressured and stressed, and we just don't know if we have time to justify that. And that's all okay. We're human, right? However, it gives us permission to stick to our ground and our gut and our clinical guns, because we have that responsibility no matter what. Do we have to figure out how to word documentation to do our best to get coverage with insurance? Of course. Do we have to make sure we're maximizing that capacity for access for our clients? Absolutely. We also need to set realistic expectations of what's within our scope of practice and what's not. And we also have to self-reflect on whether we're actually upholding that, questioning, am I doing this because I've been told that's the way to do it? Or am I doing this because that's what I've learned in my skill set? And here's the other thing, and I'm hoping that this gives some listeners a little bit of reassurance, at least in acute care or at least in older adults or adult populations. Our evaluation codes give us permission to look at value. In October and in January, patient-driven models and the way that Medicare will be paying gives us permission to step up and be the solution. So we no longer have to sit on the sidelines and say we will do what the system tells us. We get to define the system based on the new rules. We get to speak up for ourselves. We just have to have the courage to be able to do it.
Yeah, and I think it really starts kind of on that individual therapist level, and that if you are learning from somebody who might not be doing it the way that you think that we're capable of doing and the way that you want to be doing it, and then you're kind of squashed by this overall system that's saying you have to do it this way and we won't fund for it this way. What do you say to somebody that might be in a situation like that? Like, do you have a piece of advice to help somebody, give them the courage to stand up and advocate for what we can do, especially when a lot of the other people, maybe outside of our profession, are telling them it needs to be done this way and not the way that you want it?
Yeah. Is there one piece of advice I can give? No, but I can help by giving at least one. In that, set your intention for being in alignment with your values. Also, use the evidence provided to you by your network and resources, whether it's AOTA or state association or a trusted mentor. Utilize your resources. That's why I created my mentor program for occupational therapy providers, so they can have the resources to be confident in these situations.
So you definitely just segued right into what I wanted to talk to you next about. And I know that you had kind of mentioned that you got put into this supervisory role at work. And then now you've brought up this mentorship program that you have developed and are a part of. And I'd love to hear a little bit more about what you have going on with the mentorship program and everything that you're up to over there.
Yeah, so aside from the supervisor position where it kind of happened, and it was a decision mutually that had happened between my colleagues and my supervisor and myself, and figuring out, is the right fit for each other? The mentorship program is a passion project that actually stemmed from the beginning of my practice in 2011. It was something that came out of a result of being a traveler in an environment that was not equipped and did not have the resources to provide a new grad like me with the necessary information that I needed to go in to be successful. As much as my peers were fun and they were going through the motions, I felt lost. I learned a lot about being a travel therapist in a new setting, which it was a skilled nursing facility for me, in that 1 month of being there and then moving on to a long-term acute care for 5 months as a traveler. I traveled for 3 years total in 8 different settings or 8 different assignments. But this project came from that because there were moments in my practice where I did not feel confident. I did not have the courage to speak up, and I just didn't know what to do in certain situations. And so I wanted to create something where others can feel confident, not only in their professional life as an occupational therapist, but a personal life. Because I think you understand this, Sarah, that occupational therapy for people like me is more than just a job. It's my livelihood. It's how I breathe. It's how I live. It's what gives me joy every single day. And I didn't get into this profession just to settle. I came into this profession to actually feel like I'm serving well, but also feeling like I can do this and I can speak up and I can have the confidence in what I know already, and also have the confidence to know what I don't know and how to go about that when I come to those certain pathways in this profession. I wanted a platform where I can continue to grow as well as those mentees I serve. I want them to feel safe in a space where they can grow throughout their practice. So that's where that came from. The way that it's developing now really is a matter of what my mentees need, and there's, like, we just talked a lot about the challenges that are faced, not just in acute care, but in the system of healthcare in general. And those things are going to continuously come across our way, and we're going to have to figure out how to navigate it together. And I just want to be that space for our practitioners. It doesn't matter where they start or where they end in their practice. They could be just starting out. They could be seasoned and have been around the block for years. It could be those who are transitioning from traditional practice in a clinic or a hospital or whatnot for the 9 to 5 to business. Wherever they are in their space, they can still utilize tools to feel equipped in that.
You are totally speaking my language. When you made the comment that OT is more than just a job, yeah, hands down, I'm a firm believer of that. It's life. It really is life for me and for so many other practitioners, and even for the students that are out there right now. And I think just kind of as you were talking, some of the themes, some of the terms that kept popping up into my mind were that you developed this out of necessity. You developed this because you needed the resources and you needed the support, and it wasn't out there. But then also kind of this growth mindset of being able to kind of help you continue learning, but then also be able to pass on some of the knowledge that you've picked up in your time as a traveler, and now since being in the setting that you've been in now. And then also just this connection with others and having that community involvement where we are learning from each other and we're helping them and they're helping us. And it's just this absolutely beautiful thing that can happen when brilliant minds get together. And I think this just ties so nicely into, I think, kind of one of those foundational levels of our profession of being a lifelong learner.
100%. 100%. There's so many things we come across, not just learning how to navigate difficulties from external barriers, but also our own internal barriers. There are times where we feel like we've screwed up so strongly. And I am definitely one of those people where I feel like I screw up all the time. And we just want to figure out how to navigate that and navigate that confidently. How do we continue to convey to the world confidently without faking it till you make it? Because I know that seems to be the default. A lot of people will say, I'm just going to fake it till I make it because I feel uncomfortable. But I want people to truly feel comfortable in their own skin. I want people to truly feel like, I've got your back. We're in this together. You are human, and that's okay. And you're still going to be an amazing occupational therapy provider, like no matter what's happening.
Yeah, and I think it is. It's that confidence piece. And I see it so many times with my students and with new grads that I come across where they feel like they don't know what they're doing. And it's not that they don't, it's that they just don't have the experience and they don't have the years of being in the field. But it's really important to instill that confidence piece, not in a cocky, I know everything type of manner, but more along the lines of, I am skilled, I have experience. If I don't know the answer, I can be resourceful and go figure it out. I don't need to know everything at this moment. And I just feel like time and time again, I'm constantly trying to explain that to my students of like, you guys know this, you know it. You think you don't, but you definitely know it. And really just trying to give them that confidence of it's okay not to know everything, but I already know a lot more than I'm giving myself credit for.
That's actually an incredible asset to their clients. Like, so we've had 3 fieldwork students in 3 years at my hospital currently, and each one of them are such a blessing because they have taught us in our department what they've brought to the table, what their OT lens has seen in our clients that we wouldn't have had if we didn't have them in our space. And even though they feel like they don't know the exact intervention or the exact assessment for their client with that specific diagnosis, they still have something super special that we cannot replicate without them being there. And I feel so strongly in helping them capitalize on that because that's what's making them a good OT. That therapeutic use of self, that rapport, that ability to see that client from a fresh pair of eyes, that's something that you can't teach a veteran OT practitioner. You cannot teach them how to walk into something for the first time and notice the observations for what they are in the facts rather than judgment. I can't tell you how many times I've seen colleagues, and this is a blanket statement. This could be siloed. This could be in our department. It doesn't matter. All across the board, there's judgment and there's bias that comes with experience. There's a way that we see things by the way that we've been practicing. And I'm not saying that we're not good at what we do. I think experienced therapists have so much value and we just need to capitalize on getting our message across. So that's a completely different way of mentoring. But for our new grads and students, their fresh lens is so priceless. And I just want them to feel confident in conveying that to their patients and to their clients and to their clinical instructors.
Yeah. Yes. 100% agree with that. It's so important. And I think it's just something that they might not believe right away, but once they start practicing, they're going to realize how important and how valid that skill really is.
Yeah.
Now, I know that all of your mentees and everybody that you've worked with, the students, they've all learned a lot from you. But I'm curious. I'd love to know maybe one thing or maybe a couple things that you've learned from them.
There's a couple things, yeah. That we are the same, that we're both human, that there's still a lot to learn, that I should never stop giving up on asking questions and understanding more. They've taught me to be more curious and to continue to keep doing what I'm doing because there's so much more I need to discover from my colleagues. I consider my mentees my colleagues. They're not below me. They're not above me. There's no hierarchy. And it's just a matter of how can I continue to grow alongside you? They've taught me that. They've also taught me not to give up on this need. You know, you had mentioned something about that I saw a need and I created it. And they're the very reason why I don't give up, because there's times where I'm like, I'm not making as much headway as I'd like to in terms of the amount of people I want to help in one moment. And I feel like I should have helped them like way more people like yesterday. But then there's that one mentee that made it all worthwhile to keep moving forward, which is very powerful for me to continue to do this. Because I think as humans, if we're not continuing to get momentum all the time and we're not getting validation all the time, we want to give up. But we have to not just see what feedback is coming from those we're helping, but we also have to know our why, and we have to know why we're doing this. And so they're the reason why I do this. Because I don't want to leave anyone in the dust. I don't want anyone to feel like they don't have someone behind their back.
I love that you said that we are the same. And as I was asking you the question, I'm like, what would I say? And as soon as you said that, I'm like, that's exactly it. I constantly, with anybody, whether it's a student or a new grad, maybe even somebody that's been in the field for a while, but that's switching to pediatrics or anything like that, I'm always trying to highlight to them the similarities of our path and how I felt this lack of confidence, how I felt that I didn't know what I was doing very early on. And maybe some moments still have that where I'm like, I've never seen this before. I've never been faced with this and what to do about it. But it's really instilling in them that they can do this. And just because they can look at me now and say, well, but you've done all these things, it's really important to not judge your beginning to somebody else's middle or maybe end or somewhere where they're further along in the process. And I'm constantly trying to point out these things of like, I was just like you. I remember going through this learning experience. I remember struggling at this moment.
It's so true. I kept nodding. I was nodding and nodding and nodding as you were saying that. I just was like, yes, yes, yes. Yes, 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 yes.
Yeah.
You know, it's interesting. So, for example, sometimes I'll hear from my mentees or I'll hear from fieldwork students or whoever, you know, they'll say things like, I wish I could be like you one day. But I'm like, you already are a therapist. Like they're students, you know, or they're practitioners that are a few years out, or they're a practitioner 10 years. They wish they could be like me one day. No, no, no. You are an occupational therapist right now. Like you don't believe it because there's all these false beliefs, but you are a therapist. You signed up for this. You live and breathe this. You are this, you know, and it comes down to the mindset. It comes down to the belief. And it's not just affirmations. It's not just good self-talk. It's truly practicing towards that vision and that value that you've always wanted for your practice.
Actually, I have a story about that. This was a couple summers ago, and I want to say it was like midway through a level 2 experience for one of my students. We were just debriefing about a kiddo that we had worked with, and it was a difficult session. And there was a point where I could tell that the student was struggling, but I also knew that I needed to back off, give some space, and let them kind of go through this learning opportunity. And we were in the car afterwards kind of talking about this. And the student said at one point during that session, especially when things got rough, the student mentioned, I thought, what would Sarah do? And I cut the student off right there. And I was like, no, like, don't think about me. You are the therapist right now. What would you do in this situation? And really just try to kind of flip it and be like, this isn't my kid anymore. Like, if I'm not here, what would you be doing? And really trying to empower them to start thinking it's not, how do I please my supervisor? How do I do the best work of what they want me to do? No, you do the best work for yourself and for your clients.
My fists are up in the air. Yes, like boom. Yes, I agree. From day one, students should be told, like you tell them, I tell them this, they should be told, you are an occupational therapist or you are an occupational therapy assistant today. You're not that when you pass your boards. You are that now. This is your client. This is your practice. You're just putting together a bunch of pieces that work for Jane, right? So let's say Jane sees Sarah's way and Alexis's way and Edward's way. What's your way? Considering all them, but what's your way, you know, and crafting your own practice, not replicating or needing to make a carbon copy of what looks perfect, but what do you see in your heart and your gut works alongside your client with, you know, you and them, just you and them. And you've got it. You've got it.
Okay. So I have to ask this. This is going to be hard. I know this is going to be hard. But if you could give just one piece of advice, and this could be for a student or a new grad or a fellow therapist, just one piece of advice. And maybe this is something that, maybe it's a question you get a lot of like, how do I deal with X, Y, and Z? Or how do I do this? What would be just that one piece of advice that you could give to somebody? And I know it's totally broad. I'm leaving it broad.
No, it's perfect. I always give this piece of advice to experiment. A lot of the times, and I say this often, and I've said it on another podcast, and I say it regularly on my social, and I tell my mentees often, failures are deposits into your success. I say that all the time. It's one of my mantras. You have to be willing to experiment in order to get to the other side. You have to be willing to mess up. If you're not willing to mess up and trip and fall and fail, you'll never get to the other side. You will never feel what it feels like to be on the other side. It just doesn't happen without experimenting. And you learn from your experiments because some of them are mistakes and some of them are wins. And you have to be willing to try.
That is such great advice. Such great advice. Because I think a lot of times people feel that they have to be perfect before they do something. They have to be perfect before they apply for that dream job. They have to be perfect before they start that product or they start that company or they do whatever it is that they want to do. And it doesn't have to be perfect. If you don't start and if you don't try, if you don't experiment, you're never going to know what that potential could be. And so thank you. I'm speechless. I don't know what to say. That is amazing advice.
Of course, no problem. And here's the thing for the listeners out there. I used to be that scaredy cat. I used to be that person that was afraid to try, to speak up, to do. And one day, when you realize that your goal or your vision or your mission is bigger than you, then all you can do is fall, even if it's scary, because once you hit the other side, hopefully you will find, wow, I'm so glad I did that because it taught me never to do this again, or it taught me to always do this every time.
Yeah, me too. I was that person. As you're talking, I'm like, yep, that was me. I was scared to ask questions. I was nervous about doing things. I didn't want to do it the wrong way. I didn't have the confidence. And I'm so glad that I did push myself. And I'm sure you feel the same way, that you pushed yourself to kind of overcome these challenges and grow and learn and continue to learn. Because I feel like the things that we have seen and we have done, they've been life-changing for me. And I think that really just kind of ties into what we've been talking about here. That's why I try to instill that in others, because I was that person. And I want them to see, oh, you were that and now you're where you're at. Okay, I can do it too.
Right. 100%. 100%. Yes.
If people want to learn more about your mentorship program or just kind of hear more about what you're up to, where is your home on the internet?
Yeah, so you can come hang out with me on Instagram at 8, the number 8, Alexis Joelle. And if you're wanting to find out more about the next release for my mentorship program, it is a beta coming out. I think this is our 3rd beta at this point. You can sign up at creatingconfidenceinOTs.club, and I will provide you with information as soon as things are released, in addition to other resources that might help support your confidence in being an occupational therapy practitioner. Yeah, so that's it.
Awesome. Well, I'll definitely make sure that I link to all of that in the show notes. So if anybody is curious, definitely head over to the show notes and I'll have links to everything so you can find Alexis's Instagram account, link to her website, all that good stuff. So, Alexis, I have one more question for you.
Yes.
One word to describe occupational therapy.
Choice. It kind of goes in the theme of what we were talking about, but it's deeper than that. We get to help support and facilitate choice for our clients every single day. We get to give them the opportunity to have choice in the next stages of their life. in occupations they participate in the way that they live their livelihood, in their health and well-being. And we also get to decide and have choice in how we do that as practitioners. And choice is so powerful. We can choose something and it might provide us with a negative consequence, and we may choose something and provide us with a positive consequence. And in either way, our choice in how we support our clients will impact their life forever.
Beautiful. I feel like that word ties so much about what we were talking about today. Mm-hmm. And that's amazing. I am so glad that we had the chance to sit down and chat today and hear about your story and hear about your passions. Honestly, I'm motivated. I'm inspired. I'm ready to go to just seize the day and just go and get out there and do. And so thank you so much for coming on the show and sharing your story with us.
Thank you, Sarah. It's been such a pleasure. And I just appreciate having another soul OT out there to collaborate with.
Hey, before you go, I just wanted to say thanks for listening to today's episode. If you want to further the discussion, go to our website, otforlife.com, and join our Facebook group. If you like us, here are 3 easy ways to let us know. 1, share our podcast with a friend, colleague, or anyone interested in occupational therapy. 2, leave us a review on iTunes or anywhere this podcast is found. 3, subscribe to us so you don't miss out on any upcoming episodes. Thanks again. We'll catch you next time, OT for Lifers. Oh my goodness.
Oh my goodness.
Too funny.
Oh, crazy.
Yeah.
I'm in PJs, by the way, so.
I'm like halfway dressed because I have to like rush out at the end of this, but yeah. I'm so weird, and I don't like, if I'm putting on like normal pants, like not like yoga pants, I don't like sitting in them for a long time because they get stretched out. So I was like, I'm going to put on just my sweatpants and then I'll change really fast when we're done.
Perfect. Oh, I totally have a word. Yeah, no, I live by this word. So anyways, when we get to it.
Yeah, you're already ready. You're already like looking way past. We have to do the episode, Alexis.
Exactly.
And now I lost where I was going with that.
Yeah, you just went so far in your journey that you're like, wait, where I need to get my map out. Where did it go?
So, I was like, I had so many things to say, and then they all just disappeared. Oh my goodness. All right.
Shoot, now I forgot it too.
I rubbed off on you.
Oh, you did. I totally forgot what I was going to say, but it's on the tip of my tongue. I know it. It will come back. Whatever.
No, we're fine. It's like, it's always something, you know.
Oh yeah, no, totally. I mean, I can't even tell you how many times there's been glitches, and those have been the best things. So
every therapist did I even say that right?
I don't know. What was I saying?
It's fine.
Yeah.
That's the beauty. I can just cut all of this out and nobody will even know that we had issues.
Oh, but it's always with the good stuff.
I know.
What was the last thing you heard me say?
It was right before you said this might just be an opinion. And so like right on that last little bit of what you were talking about.
Cliffhanger.
I know. I was like, what?
So that's good. That's good. It could be a cliffhanger. And you have like an interruption. You have like a commercial break. And you're like, stay tuned. Dun, dun, dun.
Here's a word from our sponsors.
Exactly.